Our next speaker is Alice Shaw. She is known to many of you. She is an associate professor of medicine at Harvard Med School, attending at Mass General Hospital, and a clinical investigator at MIT's Koch Institute for Integrative Cancer Research. She went to Harvard as an undergraduate and studied biochemistry, then went to Harvard Medical School and got an MD and a PhD, because an MD would be too easy, and then went on to internship and residency at Mass General Hospital just down the street, then to Dana-Farber for her fellowship training and what we call this Preparation H training. So she has since been synonymous with the development of the ALK story. Basically, the Crizotinib story began with clinical testing of the agent here and also at Colorado, and then after Crizotinib was approved, has been leading the work in the second generation ALK inhibitors, including Ceritinib that is now FDA approved. We're going to hear about these agents, and we're going to be hearing about some other ones that are options that may not be top of mind, and how to integrate all of these considerations. So with that, let's welcome Dr. Shaw.
Thanks, Jack, and thanks for inviting me today. It really is an honor for us to be here and to be able to meet all of you and share our perspective on this field and these new drugs. Okay, so I only have about 20 minutes, and so I've kind of organized it into several sort of main sections, and Dr. Doble gave a really nice sort of overview of the field of resistance, and so I'm only going to give a little bit of background, and then we'll kind of jump into some main themes about the new drugs. So first I wanted to talk a little bit about ALK and ROS1. We often get the question, why do we kind of talk about these two targets together? Well, most of you probably already know this, but just to bring the point home, ALK and ROS actually turn out to be very similar kinases. They're very closely related, and in fact, within the tyrosine kinase domain, which is the active site of these enzymes, they're very, very identical. They're about 77% identical in terms of amino acids, and this slide is just highlighting the similarity between the two, and then you can see some structural modeling that was done showing an overlay of the two ALK and ROS1 tyrosine kinase domains. You can see how similar they are with the green and the gray ribbons almost precisely overlapping. And then Crizotinib, of course, binding into that active site, as you heard about from Dr. Doble, and being able to shut off these two kinases very effectively. So in fact, Crizotinib, we often have really just talked about Crizotinib as an ALK inhibitor, but in fact it hits other targets, ROS1, and others even beyond ALK and ROS1 that you may know about, like MET and others. So a lot of what we'll talk about today is really on ALK, but as Bob mentioned, many of these sort of principles are relevant to ROS1 as well. This is a pie chart that I made a few years ago, actually, just to emphasize some of the key principles around what we know about Crizotinib resistance. And again, Bob's already talked about a lot of this, but I did want to just highlight a few themes. One is that we do see the acquisition of new secondary resistance mutations as a common cause of resistance. We see it in about a third of our patients who become resistant to Crizotinib. And the reason I've colored it kind of in a rainbow over there is to really emphasize that it's rather interesting that you can develop any of a number of different resistance mutations. So unlike EGFR, which you heard about this morning, where you have a very common T790M mutation that causes resistance in about 60% of patients on EGFR inhibitors. In ALK, it's a bit different because we see multiple mutations that can arise in the setting of Crizotinib resistance. The gatekeeper mutation for us, for ALK, is L1196M, and that is the most common one that we see. This slide also highlights that there are a substantial number of patients where we don't identify resistance mutations, and Dr. Doble was referring to this as well. So not all resistance is due to resistance mutations, although a sizable proportion of it is. In fact, we do see other mechanisms, including activation of alternative signaling pathways, what we call bypass tracks, and you saw that nice illustration of sort of the townhouses that Dr. Doble showed. So you can turn on other signaling pathways that allow you to bypass ALK inhibition altogether and to then allow signaling down through all the same pathways and drive and stimulation of the growth of the cancer cells. The other thing I wanted to mention on this slide is that we do think that another mechanism of resistance that may be relevant for crizotinib has to do with the possibility that over time, crizotinib becomes a little less effective. And so you start to lose the ability of the drug to effectively turn off the target. And this is all somewhat speculative based on the results of these really more potent next generation inhibitors, but there's this idea that there could be pharmacodynamic or pharmacokinetic issues with crizotinib that lead to, over time, subtherapeutic inhibition of the target. And that could explain why so many of these next generation inhibitors that are just more potent are all able to be so effective in the setting of crizotinib resistance. So this is a picture of a sort of a diagram of the active site of ALK illustrating these mutations and where they're located. So you kind of get a sense that in general, most of these mutations really inhibit crizotinib binding. So they basically replace one residue with another residue in the active site, and now crizotinib can no longer bind. And on that sort of histogram on the far right, what I've done is just map out the frequency of the different resistance mutations that we see. And you can see, again, the gatekeeper here being the most common. This is as reported in the literature by many groups. But there are many other mutations, including G1269A, that was first discovered by Colorado, very, very common as well. And then sort of a smattering of other resistance mutations throughout the ALK tyrosine kinase domain. To sort of more, I think, graphically illustrate how these mutations disrupt binding, this is actually work that we did with ROS1 and studying resistance that developed to crizotinib in one of our ROS1 patients who had initially done really, really well, and then she relapsed on crizotinib, and we studied her resistant tumors and found that she had this mutation within ROS1, so within the tyrosine kinase domain of ROS1 called G2032R, and this is actually analogous to an ALK mutation that we know about, G1202R. And really, I just wanted to highlight, again, how this mutation leads to resistance. And you can see here in the normal unmutated ROS1 that the crizotinib drug is able to bind as predicted. And then once you replace this residue, the glycine, with a larger residue, this arginine, here you can see that it completely blocks or interferes with crizotinib binding. And similar modeling has been done with the ALK G1202R mutation as well. And this probably explains why these two mutations in particular are so resistant to many of the ALK inhibitors, including these next generation ALK inhibitors we're going to talk about. So here they are. These are the 8 next generation ALK inhibitors that are currently in the clinic, and a number of them also inhibit ROS1. I've sort of made a column here to indicate which ones also inhibit ROS1. We've already heard about many of these today. But I just wanted to show that this field is pretty impressive in terms of how quickly these new drugs have gotten to the clinic and are going through clinical trials. Bob showed a nice timeline in terms of how quickly we can develop these drugs. And I think that is really a testament to everyone, not just the investigators and the sponsors, but really the patients who participate in these trials to allow us to gather this information. You can see here that these drugs are all in various stages. We heard that Ceritinib or Zycadia is already approved, and it is currently in phase 3 trials. Alectinib is originally the drug that Chugai had made. It's also sometimes called CH-5424802, and that drug has FDA breakthrough therapy designation. So we anticipate that drug could be approved in less than a year, so that would now be 3 ALK inhibitors that are commercially available. And then, of course, there are all of these other ALK inhibitors that are also moving quite quickly in development. So let's talk about these sort of as a class, and as Dr. Dobel mentioned, these ALK inhibitors are pretty impressive because all of them are showing very high levels of activity in the setting of crizotinib resistance. And I wanted to say that when we first started working on some of these new drugs, and this was back in 2010 when we were thinking about the trials and who was most likely to benefit, we were really imagining that those patients, the 1/3 of patients who relapse and have crizotinib resistance mutations, might be the ones who benefit the most from these more potent ALK inhibitors, many of which can overcome resistance mutations. And we were thinking that maybe the remaining 2/3 of patients who don't have resistance mutations might not be as responsive. And in fact, as we've seen, these more potent and chemically distinct ALK inhibitors really do seem to be effective in most patients, and this really is regardless of whether or not they have a resistance mutation or not. So we saw this waterfall plot already, and this is, again, I show this one because this is the largest data set that we have for a next-generation ALK inhibitor. This is Ceritinib, and as you all know, all of these downward bars represent individual patients whose tumors have all shrunk. And I wanted to just show this because even though we often say that the response rate is 50% or 60%, that really refers to those patients who had a greater than 30% reduction in tumor volume. But really you can see that most patients do have some tumor response to Ceritinib, and this is true for all the ALK inhibitors. So even though they might not meet the 30%, many of them are still having tumor shrinkage and having a really meaningful response. So this really illustrates how potent these new next-generation ALK inhibitors are in the setting of crizotinib resistance. And I think what was also amazing when we first started studying these drugs is that these patients have already failed crizotinib, and it wasn't clear how well these new drugs would work. And in fact, what we've seen is that these new drugs really are capable in many patients of re-inducing a remission. Crizotinib can induce a very fast response in many patients, and what we saw in patients who developed crizotinib resistance is that we also saw kind of a reinduction of remission, which is not what we were expecting. But here's an illustration of this. This is a patient of mine who had a lot of disease. This is a PET scan, and all the dark areas show metabolically active sites, growing sites of cancer in his chest. And just after 3.5 weeks, he had this really rapid response. And clinically, of course, he completely turned around. So these new, more potent ALK inhibitors work very, very quickly. As Bob mentioned, the data with Alectinib does look very impressive and looks very similar to what we've seen with Ceritinib. This was just recently published, so I wanted to show you. This is the waterfall plot with Alectinib. Fewer patients, but the overall picture is the same, that most patients who are resistant to crizotinib will respond to a next-generation ALK inhibitor, in this case, Alectinib. So that brings us to a comparison now of the most advanced next-generation ALK inhibitors that are in the clinic, Ceritinib, Alectinib, and then the ARIAD compound, AP26113. And as we mentioned, you can see that the response rates are all very similar among the three drugs. We have some progression-free survival data with Ceritinib. My sense is that we'll also see very similar durations of response to these three next-generation ALK inhibitors. We do see very good CNS activity with these ALK inhibitors, and we'll talk a little bit more about that. And so really the question boils down to, well, once these drugs start being approved and now we have patients who have an option, how do we pick which one to use for our patients? And I think at least part of that decision will be based on what we know about the side effects of these next-generation ALK inhibitors. Ceritinib, which is currently approved and commercially available and has really the most data behind it in terms of crizotinib resistance, is a drug that has side effects, particularly GI side effects. I think they're quite a bit more than crizotinib and quite a bit more than the other next-generation ALK inhibitors. But in my experience, those GI side effects can be well managed. I would say the best way that we've found to manage those side effects is really to bring down the dose of Ceritinib, because it is a very high dose that was approved, the 750 milligram dose on an empty stomach. It turns out to be kind of a tough dose for most patients. And so when I'm treating patients on this drug, the best way we have to make the drug very tolerable is just to bring down the dose, sometimes 1 or 2 dose levels, and to actually take the drug with some food. Alectinib, the Chugai compound, is extremely well tolerated. I would say the GI side effects are quite minimal, but there are other side effects with Alectinib, and we certainly do see side effects like myalgias, muscle aches very early on, and these can be quite significant and require us to hold the drug and often dose reduce. But as patients continue on, those muscle aches tend to dissipate. So overall, I would say Alectinib is quite tolerable, and I would say roughly comparable in terms of side effects to Crizotinib, and probably easier than Ceritinib at its standard dose. But another thing I would note about Alectinib is that the dose that's the dose that's going forward as the standard dose is 600 milligrams twice a day. And that dose actually is not really the maximum tolerated dose. They went up as high as 900 milligrams twice a day and actually settled on 600 milligrams twice a day just because it was a very tolerable dose. Whereas for Ceritinib, we did push it all the way to the maximum dose. And then finally, the Ariad compound, I'll just mention overall, is also quite well tolerated, but the one very unique thing that we've seen with the Ariad compound that we haven't seen with others is a pulmonary toxicity that happens very early on, even after a single dose of drug, and that can be very significant. And so I think that needs a little more study, and in fact, Ariad's, this drug is being explored in a randomized phase 2 study and will establish the best and safest dose of this drug. So let's talk about the CNS. This is a very important topic because all lung cancer patients, of course, are at risk for having spread to the brain. And I would say, in my experience, ALK patients in particular are at high risk for having metastatic spread to the central nervous system. So this is a very common scenario where we have a patient here who had no brain metastases when we met, and she started on Crizotinib and did great, had a beautiful response systemically. But then at 9 months, she was actually her systemic disease and her body was still responding beautifully, but she developed headaches, and we found that she had multiple new brain metastases. So very common situation, and it's been shown that the CNS is the most common site of relapse in patients who are on Crizotinib. The other thing, as Bob was mentioning, the CNS really seems like it's a sanctuary site because Crizotinib does not have good penetration into the brain, and so we do see these CNS relapses quite common, and not just in the brain, but also in other sites in the CNS that traditionally have not been seen that common. So, for example, leptomeningeal disease, as well as actual spinal cord metastases, as shown here in this patient. So we used to really not see that much, and now we're seeing it more and more on these small molecule drugs like Crizotinib. So this is a big problem that we're seeing in the clinic. So the good news is that, as I mentioned, these next-generation ALK inhibitors do seem to have very good activity in the brain. This is data on Ceritinib that was shown at ASCO, showing a patient of Dr. Tan's who had this very nice response in a rather large brain metastasis, as you can see here, and this was a very durable response. He was still on study after well over a year with control of his brain metastases. And as we saw in the last presentation, Alectinib has also been associated with very impressive brain responses, as shown here. Again, some examples of patients of Dr. U's where their brain metastases really resolved. And then here's some recent data that was published documenting a response rate that was actually similar in the brain as what we see in the body. So Alectinib clearly has very good penetration into the brain, and I would say the data so far suggests that Alectinib is reaching a high level in the brain, and probably higher than what Ceritinib can reach in the brain. So now these drugs look great, but they also have kind of a finite lifespan. We heard from Bob that Crizotinib lasts for some patients anywhere from, on average 8 to 12 months, although we have many patients who have actually gone beyond 3-4 years on Crizotinib. These next-generation inhibitors, we also face a similar problem with resistance that develops. And typically the resistance develops, I would say, in the 6 to 9 month range. But again, we have some patients who've been on these next-generation ALK inhibitors for 2 to 3 years already. So again, there's that potential that these drugs can last a long time. But on average, we do see resistance emerge, and often in less than a year, even on the next-generation ALK inhibitors. So what do we know about resistance to the new ALK inhibitors? Well, we're just beginning to learn a little bit about this. This is a patient of mine who's actually here today. And this really shows you how resistance can evolve in a patient and how the drug that we're treating with really can shape the evolution of resistance. So she did very well on Crizotinib, had this almost complete response, as you can see here, and then unfortunately relapsed at about 3 years of Crizotinib, and you can see almost the same tumors growing back here. And she went on to Ceritinib, one of our first patients on Ceritinib, and had this sort of, again, re-response or reinduction of remission here. And that lasted about 15 months or so. And after 15 months, again, we just started to see the regrowth. And so for her, we had undertaken a number of repeat biopsies, so biopsying these resistant tumors here and here to try and understand why her cancer had become resistant. And we showed in the original tumor that she just had the actually EML4 ALK rearrangement, no other mutations. And then when she became resistant to Crizotinib, she had this new mutation, which had not been reported before, S1206Y, which we studied in the lab. And it seemed like a very sensitive mutation to next generation ALK inhibitors, although one that's resistant to Crizotinib. And indeed, as I said, clinically, she did respond very well to Ceritinib, as we would have predicted from the lab experiments. And then what happened when she became resistant to Ceritinib? Well, we sequenced her ALK gene again, and this time, in fact, this mutation, which we knew would be sensitive to Ceritinib, was no longer detectable. And in fact, her new resistant tumor had a new and different ALK resistance mutation, and this is the G1202R mutation that I had mentioned to you earlier in the talk as being one that really confers very high-level resistance due to steric interference with binding of the drug. So here you can really see how the tumor really can evolve in response to the small molecule drug that's inhibiting the growth of it initially. And so now we've accumulated some more data on patients who've become resistant to Ceritinib. This is a study that we published a few months ago. This is a collection of resistant tumors. These patients had all been on Crizotinib and then went on to Ceritinib and then relapsed on the Ceritinib. We've already talked about one patient who went from 1206 to 1202. And what you can see here is that we do see the tumors changing in response to the Ceritinib. We see another patient who developed a 1202R mutation, actually two other patients who developed 1202R mutation, and two other patients who developed another mutation, 1174. And some patients who don't have any resistance mutations and yet are very resistant to Ceritinib, again, highlighting that other mechanisms like bypass tracks can be very relevant. But I wanted to show you this because this really shows you that we see a different spectrum of mutations emerge in response to Ceritinib compared to what we saw with Crizotinib. So we still have lots more to learn, but I think this is one of the emerging themes that we really can change the genotype of these resistant tumors with the drugs that we use. And notably, we didn't see the most common resistance mutations to Crizotinib, the 1196M or the 1269A, and those are actually very sensitive to Ceritinib. I pointed out that there were a number, about half of the patients who don't have resistance mutations, and so for us that really suggests that as patients are becoming resistant to even the more potent ALK inhibitors, that we are definitely going to have to start thinking more beyond just single drug, single ALK inhibitors, and really start thinking about combinations because we need to be able to overcome those resistant tumors that no longer even depend on ALK. And so before I talk about a few of the emerging combinations, I wanted to mention one other thing that's come up, which I think is very exciting for us, in that we haven't quite figured out how to integrate all of these ALK inhibitors. In fact, the most common question I get when I give talks about these ALK inhibitors is, well, why do we need so many? You know, there's like 9 ALK inhibitors out there already, and do we really need these? And I would say right now it seems like we may need them because we can actually see that some of them work better on some mutations than others. And as I'm going to show you, you can see that some patients can actually do well even after Ceritinib, a second-line ALK inhibitor like Ceritinib has failed. So I'm going to give you 2 examples of this. This is a patient of mine who had initially been on Crizotinib, did well, relapsed, and then went on to second-line Alectinib and did very well. But he developed resistance to Alectinib, and we found that he had this novel mutation, 1171, which actually turns out to be very resistant to Alectinib, but very sensitive to Ceritinib. And so then he went on to Ceritinib, and he had this nice re-response that lasted over 7 months. So he was able to get time from each of these ALK inhibitors, so a total of 3 inhibitors. And here you can see evidence of this in his liver, where he had quite a lot of disease after he had relapsed on Alectinib, and we were quite worried about him him. But you can see here, Ceritinib was able to overcome this resistance even in the third-line setting. And so he was able to derive a lot of benefit even from a third ALK inhibitor. And now what we're seeing a lot is this situation where we have patients who start with Crizotinib, then go on to Ceritinib. They're doing great on Ceritinib, but as I mentioned, Ceritinib does not have as good brain penetration as some of the other drugs like Alectinib. And these patients, often we will see evidence of disease, again, growing in the brain, in the central nervous system. And what we've started to see now is that if those patients then transition to a third ALK inhibitor and one that's more brain penetrable, we can get a lot of benefit from that. So here's an example of one of my patients, again, who went through this exact sequence, and after, while being on Ceritinib, developed many, many brain metastases, as shown here. Again, very concerned about him. Got him onto an ALK inhibitor that's much more brain penetrable, and you can see he had pretty much a complete resolution of the brain metastases. So I think there's a lot of hope that we may be able to use not just 2 ALK inhibitors, but maybe potentially 3 ALK inhibitors, and that will depend both on where the recurrence has happened and also what the underlying mechanism of resistance is. So finally, just to end on both the combinations that I mentioned, and I want to highlight one drug, which Dr. Doble mentioned. This is the new Pfizer drug, which is one of the more brain-penetrable ALK inhibitors. And in addition to that, the reason I think this drug is very important is because it is, at least in all of the preclinical studies, very effective against all of the known ALK resistance mutations, including the G1202R mutation that I mentioned. So this is just some of the preclinical data showing its efficacy against ALK and at least the gatekeeper. And I just also wanted to highlight this is a very different structure than any of the other ALK inhibitors. It's shown here compared to Crizotinib. And here's just some data, a lot of busy data, just showing again to highlight that this drug, the reason I think it's such an important one to keep in mind is because not only can it get into the brain at high levels to treat brain metastases, but it can very effectively, at least in preclinical studies, overcome all of the known ALK resistance mutations. And that's shown kind of by all the green boxes here. So I'm just going to end on this slide. This slide summarizes some of the combinations that have been tested, some of the combinations that are currently being tested, and some of the combinations that we will be testing in the future. And again, this really takes advantage of the fact that we do know what some of the mechanisms of resistance are, particularly the bypass tracks. Dr. Doble mentioned EGFR, we know about c-KIT, we know about some of these resistance or bypass tracks, and we are trying to overcome those. So there have been some trials of Crizotinib with EGFR inhibitors. I would say that there was a real issue with toxicity there, but we are looking to combine ALK inhibitors with other EGFR inhibitors, particularly antibodies like cetuximab. MET amplification could very well become a bypass track, especially in patients who become resistant to next-generation ALK inhibitors that generally do not inhibit MET. So we do have a potential trial that will be developed looking at ALK inhibitors with specific MET inhibitors. And then because we know that there are many mechanisms, they can be quite complicated. You can, in fact, have multiple bypass mechanisms. We have a number of combinations that are trying to inhibit multiple pathways at the same time, and we've heard about some of these today. So ALK inhibitors with HSP90 inhibitors, ALK inhibitors with chemotherapy like pemetrexed that you heard about. I think we're particularly excited about ALK inhibitors and combining those with immunotherapies, PD-1 drugs in particular, and you will see some of these combination studies emerging in the clinic soon. So just to summarize, next-generation ALK inhibitors like Ceritinib and Alectinib are very effective in Crizotinib resistance, and this is even in those patients who don't have a known secondary resistance mutation. Based on the data so far, I would say that next-generation ALK inhibitors are a standard therapy for Crizotinib-resistant patients, although, of course, I agree that chemotherapy is also a standard therapy as well. Next-generation ALK inhibitors have activity in the brain, and in particular, Alectinib, as well as the new Pfizer drug, PF3922. We do need to better understand resistance to the next-generation ALK inhibitors, and I think where we need to really focus is on inhibitors of G1202R in ALK, as well as in ROS, the 2032R mutation, and we definitely need to be studying these combination approaches, both in the lab as well as in the clinic. And we haven't talked that much about ROS1, so I did want to just highlight we need to study ROS1 more. And we do have a little understanding of resistance in ROS1, but we need to gain more understanding. But fortunately, there are several second-generation ROS inhibitors. Many of them are the same drugs we talked about, Ceritinib potentially, PF3922, as well as another ALK ROS inhibitor, RXDX101. Thanks very much.